Welcome, everyone, to the December 4th Addiction Toxicology Case Conference. I'm Tim Wiegand, and we're presenting on behalf of the American College of Medical Toxicology, the American Society of Addiction Medicine, and the Opioid Response Network. This activity is available for one credit of AMA Category 1 CME. The objectives today are to describe the appropriate use of drug testing in the treatment of patients with substance use disorders during the COVID-19 pandemic, to describe what specimen validity testing includes for urine and oral fluid testing, and to review cases of testing results in clinical cases of addiction medicine. And finally, to provide guidance and resources for the treatment of substance use disorders and addiction as cases of COVID-19 increase dramatically across the nation. I'm Tim Wiegand, Director of Toxicology at the University of Rochester Medical Center and Associate Professor of Emergency Medicine. My co-moderator is Dr. Gloria Bashevitz, the Medical Director of Strong Recovery. I'm Professor of Clinical Psychiatry at the Department of Psychiatry at the University of Rochester. And as our panelists, we have Dr. Lewis Nelson, who is the Professor and Chair of Emergency Medicine at Rutgers, New Jersey Medical School, Newark, New Jersey. Dr. Kara Poland, Assistant Professor, College of Human Medicine, Michigan State University, Grand Rapids, Michigan, and Dr. Ross Sullivan, Director of Medical Toxicology at the Upstate University Hospital. He's also the Director of the Upstate University Medicine Opioid Bridge Clinic and Medical Director of Helio Health in Syracuse, New York. None of our speakers have any conflicts of interest, and I'm going to jump right in with the first case. Please keep questions and comments for the panelists and moderators in the Q&A, and the chat can be reserved for just chatting amongst oneself. So the first case we have is sleight of hand during buprenorphine administration, combining drug testing, observed dosing, and telehealth to support a challenging patient during COVID-19. This case involves a 26-year-old female with a history of opioid use disorder who reconnects with an outpatient treatment program. She had disengaged 2 months prior due to frustration over a CPS report related to intoxication and overdose with a young child in the home. And it is now mid to late October, New York, 2020. The COVID pandemic is just starting to really increase, and we're worried about travel, obviously. She'd originally been enrolled in the same program 3 different times, first in 2019 for 8 months, 2 separate episodes, and then in 2020 from February 2020 until about July 2020. And then the disengagement for 2 months, 2 to 3 months, and re-engagement. She reports use of 90 to 180 milligrams of oxycodone per day via intranasal use. She describes them as perks, but these really are the oxycodone 30 milligram tablets. There's also tobacco use, but no other prescribed medications, alcohol, or illicit substances. At the intake visit the day after leaving detox in 2019, she has a urine drug screen obtained. The detox admit was 7 days, and she'd been using oxycodone or the perks prior to entering detox facility, but denied other substances. The intake urine screen demonstrated oxycodone plus fentanyl at the detox. While in detox, she started on buprenorphine naloxone and then stabilized on an 8 milligram dose of buprenorphine, or an 8/2, twice a day. The image you see are the results from the outpatient intake with confirmation, the confirmatory results related to just the benzodiazepine positivity. And my question for the panelists is, what do the benzodiazepine results indicate? And then I'll start with Dr. Nelson. What do these results tell you about this patient?
Hi, everybody. It's Lewis Nelson in Newark, New Jersey. I mean, the simplest explanation would be that the person took diazepam. I mean, they have the metabolites of diazepam all present. Nordiazepam and temazepam are, I think, direct metabolites, and oxazepam is an ultimate metabolite. And the one we usually actually screen for when we screen for benzodiazepines alone. But this is obviously a much more comprehensive look at benzodiazepines.
Sure, thank you. I suppose it's possible that this patient could have had diazepam, temazepam, and then oxazepam. Oxazepam is Cirex and temazepam is Restoril. I really don't see those too commonly prescribed. I'm not sure what your experience is. Do you see either the separate temazepam and oxazepam prescribed?
Sometimes we'll see oxazepam prescribed for patients with alcohol withdrawal as an outpatient treatment. I mean, Temazepam Restoril used to be used, I think, pretty widely as a sleep aid, but I think most now use one of the Z drugs in place of a benzodiazepine. I mean, it's certainly, those are very reasonable explanations. I was just giving the simplest explanation, which is taking one drug and getting all the metabolites. Obviously, nordiazepam is not a drug, so she would have had to take, presumably, diazepam to get that, at the very least.
And you are correct with that. This is part of the protocol. Diazepam would be part of the protocol, this particular detox. Dr. Sullivan, can you maybe comment a little bit on if this patient's coming into a detox for opioid use disorder to potentially either detox or initiate buprenorphine, what kind of protocol would be common?
Well, obviously the most common protocol is to, recruit people onto buprenorphine as soon as possible. And with people of varying degrees of taking care of these people, some people are comfortable giving bup with people with COW scores of 8, sometimes 12. But certainly with how prevalent fentanyl is, we have seen maybe a slight increase of some people with some precipitated withdrawals at lower COW scores. So it's not uncommon to have a protocol, even like where I work here in the middle of Syracuse, where someone may have a good degree of anxiety. So it's not uncommon to maybe give somebody some diazepam while we're waiting to get the person ultimately onto buprenorphine. Some people come fully in withdrawal and ready to start, and some people just use before they walked in, but still are understandably anxious. So it's not uncommon to give doses of diazepam while they're waiting to be started on their buprenorphine.
Sure. And this protocol involves a small dose of diazepam, the buprenorphine when appropriate, some clonidine and hydroxyzine, and then for sleep, melatonin. There's a couple of other comfort medications, but this is a diazepam metabolite profile for benzodiazepines. Let's move on to the next slide, which are the buprenorphine results at the intake. And I'm wondering what these would suggest. And then if the panelists can comment at least on buprenorphine metabolism and any experience regarding profile use to determine compliance and guide treatment. Dr. Poland, do you have any thoughts?
Thank you. Kara Poland from Michigan State University in Grand Rapids. One thing that we sometimes are concerned about is misusing or diverting the medication and not actually taking it yourself. That's where the norbuprenorphine comes in, because that's a metabolite of the buprenorphine. So if there is a concern of the person not taking the buprenorphine themselves and maybe putting that tablet, that strip, or rubbing that strip with the swab for the oral cavity, or dropping a piece of a strip into their urine, those individuals wouldn't have norbuprenorphine. So when you're concerned about diversion, or there might be, or you just are generally monitoring patients for diversion, that norbuprenorphine becomes very, very helpful there. The naloxone in there is at a pretty high level, so that implies that just prior to coming to detox, perhaps this person had overdosed and was in the emergency room, and that was kind of the sentinel event to get them engaged in treatment. That sometimes is a point of contact for us as healthcare, and being very aware that this individual does look like they likely had a recent overdose, and finding out what the circumstances of that in a kind, compassionate way were, and making sure that you're aware that this individual may be a higher risk individual from a substance use disorder, and potential risk for overdose death if not continued on treatment post-detox, is something to be aware of, because as we often say, detox is the beginning of treatment. It is not treatment itself. And we're still working sometimes against others in the healthcare community, but certainly in the community-based settings where people think that after somebody goes to detox, they should they should be cured.
Yeah, some great points. Dr. Bashevitz, do you have anything you'd like to add? How do you use the metabolite profiles in your treatment? Dr. Bashevitz?
Yeah, I was muted. Now, mainly we look for a good amount of presence of the norbuprenorphine and a lesser amount of buprenorphine to make sure that the patient is not sprinkling buprenorphine on their urine. There are many, many people who still try to do that. And that's mainly what it is. Yep.
Yeah, so this is interesting. And actually, when it's referred to in this result, the buprenorphine and norbuprenorphine are total. So not just buprenorphine, it's buprenorphine and the conjugate, buprenorphine glucuronide. The naloxone result is a bit odd. That is quite high for someone taking sublingually, but the metabolites are present, and this patient had come right out of detox. Just to go over buprenorphine metabolism in general, somebody takes buprenorphine, it is conjugated with glucuronic acid, and it's also demethylated to norbuprenorphine. And then those two metabolites, the main metabolites, just some other minor ones, are then either conjugated again, if it's norbuprenorphine, to norbuprenorphine glucuronide, and or demethylated from bupgluc to norbupgluc. So you result in this end norbuprenorphine glucuronide. Most labs look at the norbuprenorphine to creatinine ratio that will fluctuate a little bit over time if somebody's on a stable dose, depending on how a patient takes it. Are they taking it meds with a dry mouth? Are they taking it now running to work? That's a shorter drive, so it's 5 minutes versus at home 15 minutes. And so there is a lot of variability that's just kind of normally built in to how someone takes their dose. But you can use these metabolite profiles to kind of guide therapy in general. And this is not certainly an absolute, except when you see as Dr. Poland mentioned, a spike, and we'll take a look at what that looks like in just a little bit.
So
let's take a.
Tim, we
go
have
ahead.
a couple of questions here in
Sure.
the question box. And one of them is an interesting one. Could naloxone at that level that we see in the result also be due to swallowing rather than permitting the buprenorphine naloxone product to be sublingually absorbed?
I think that's a great question, and that's my explanation. Again, it's not as well absorbed as it's not absorbed to a significant extent. We don't see patients with withdrawal typically even swallowing buprenorphine. We do use naloxone occasionally off-label in the hospital for constipation, and it works enterally, but those levels were pretty high even for swallowing, but some absorption does occur certainly. Dr. Nelson, do you have any? Go ahead.
Yeah, I mean, I actually think it's less bioavailable by mouth than it is transmucosally, because it's pretty much eliminated by first pass for the most part. And that's one of the reasons you can give it orally for constipation. If it can interact with the receptors in the GI tract, but it won't really produce much else. But one of the things that I know, I mean, we don't really measure quantitative urine naloxone levels much, but it's certainly been studied. And the reason it's been studied in part is because there are people who get the buprenorphine combination and state that they withdraw, right? And state that they actually feel like they're having, even given properly, that they're having the, a mild withdrawal due to the naloxone. And so when people have studied this, they do show there's a very large variability among people and the naloxone levels that they wind up getting, even after the same dose among a group of people. So, I mean, while 1,200 is definitely high, and there is the explanation that Kara gave is perfectly legitimate. It's possible, perhaps, that this person could have taken it the right way and just be one of those folks who either absorbs more or metabolizes less. It is also possible that the person misused buprenorphine naloxone and injected that as well. Yeah, there's other explanations, sure. But I do think that if you want to say it's a tough one, because I don't think we really studied the use of naloxone levels from a therapeutic perspective, only from a research venue.
Right. Yeah, that's a good point about the injection as well. I can say in clinical settings where I've transitioned patients that have been on buprenorphine to the dual product, when it's done appropriately, the tolerance of the dual product is the same with the mono product. I very rarely see people intolerant of the naloxone in general. So let's move on. So the next slide involves oxycodone metabolites, and we see some fentanyl. And this is, again, the same day, the day after detox. And she says she found a perk when she got home the night prior. She reported she insufflated it, but it didn't work because of the Suboxones earning me from detox, is what her words were. So what do the results here tell you about that Percocet or perk if that was all she used? Dr. Sullivan.
Well, it does seem that she used oxycodone. I mean, one thing I always think about where we live and probably most places is there a counterfeit with something else? And, or is there something else in it? A lot of times people take pills here and they end up being other things. We see a lot with people who use Xanny bars and it ends up being fentanyl. And this certainly could be the same thing here. We do have some urine fentanyl and urine norfentanyl. I can't remember exactly when this is in relation to when she first came into detox. I know that I think we said maybe there was some fentanyl use then. But assuming that was some degree of time afterwards, I would be concerned that perhaps there was some fentanyl lacing in this oxycodone. Conversely, she could have just used fentanyl at some time previous to this and just not letting us know.
What about the oxycodone profile? Is that a typical, are all of those oxycodone, oxymorphone, or oxycodone just simply from oxycodone? Dr. Nelson?
That's, again, that's Occam's razor, right? That's the simplest explanation. Certainly oxymorphone is available as a medication, that's Opana, but I would probably imagine that the best explanation would be they took oxycodone.
Right. Any other thoughts on this profile, Dr. Poland?
I don't think so. I think everybody covered things nicely. I mean, it could also be that, the Percocet that she found at home was one that was created on the illicit market and has fentanyl in it, because they do manufacture on the illicit market pills that are made to look just like the pharmaceutical grade. So I wonder if there was an illicit component of what she thought she was taking.
Yeah, my interpretation of this is as Dr. Nelson said, Occam's razor, the most simple explanation is she had an adulterated oxycodone pill, but she could have had oxycodone or oxymorphone with oxycodone and fentanyl or heroin that was just fentanyl with some oxycodone and oxymorphone, but most likely she just took oxycodone adulterated with fentanyl. And, this slide just indicates the increasing prevalence of counterfeit pills. This is a photo from the DEA site with counterfeit 30 milligram tablets that contain fentanyl. Other classes of medication are also counterfeited. We had a session on designer drugs a couple of months ago and discussed the increasing prevalence of counterfeit alprazolam, illicit alprazolam, which contains mostly flualprazolam, currently, historically, etizolam. Some of the benzodiazepine pills have also been found to contain fentanyl. And then fentanyl has also made its way into the illicit stimulant supply, fluctuates by parts of the country, parts of the world. In upstate New York, we have outbreaks with cocaine, adulterated fentanyl, and we have a lot of overdoses, and it ebbs and flows. But in other parts of the country, I know that there's much higher rates of fentanyl adulteration of stimulants. But adulteration of the prescription pills, and particularly the highly sought after oxycodone and alprazolam, is very common. So the following results are obtained 2 weeks after the detox discharge. Now she's in outpatient treatment and she reports occasional slip-ups, but she says she's regularly taking the buprenorphine naloxone. And so now how do these results compare to the results 2 weeks prior, which were the day after detox? And Dr. Bashevitz, do you want to comment?
So we're comparing this to the day after detox. Okay, so there is less amount of benzodiazepines in her urine. There's only oxazepam instead of there being 3 benzos listed. And that could be because it could still be from the diazepam that she possibly took as a treatment in the past, though it's getting a little farther out. It's 2 weeks, so I'd expect it to be out by now, but you never know with diazepam. I suppose it's possible. Of course, she's still using either fentanyl directly or fentanyl altered, fentanyl added to some other drug of abuse, such as pills or possibly heroin, though we see no heroin metabolites here, just the same pattern that we already saw. So, I would say that she's not using much buprenorphine because the norbuprenorphine to creatinine ratio is very, very small. And I'm assuming the way this is reported on the slide here, I'm assuming the buprenorphine and norbuprenorphine levels were actually 0. Is that correct?
No, I just didn't include them as they weren't standardized to creatinine. So she did have some buprenorphine and lower naloxone levels. Just to compare, the day after the norbuprenorphine creatinine was over 1,500. So she's at less than a tenth of that. And then compared to the fentanyl, she had very small levels of fentanyl and I think 15 nanograms per milliliter of norfentanyl. The oxycodone metabolites are about the same. So yeah, your comments are right on. Dr. Sullivan, do you have any other thoughts with comments regarding this?
And it just seems that she's, using, the last drug screen we have, it seems like she's using that same type of drug pattern or use, maybe a little bit more now. We see the oxycodone and its metabolites being persistently high, and the fentanyls, norfentanyl also appear to be higher. So it's possible she's using larger amounts of this, perhaps street or counterfeit oxycodone.
Yeah.
She's basically doing what she was doing the last time we drug screened her, but maybe even more so now.
Right. And oxazepam is the final metabolite of diazepam. If somebody's given several doses throughout detox, we can see the metabolite weeks out. So a positive immunoassay screen, would be pretty common and important if you're really worried about ongoing benzodiazepine use to really determine what does that mean, because, if a patient gets diazepam in a detox facility and 3, even 4 weeks out, longer if they have a lot of lipid, they can continue to be positive. So, but this is making me a bit worried. She has some buprenorphine in her, which is somewhat protective. Rarely do we see fatal overdoses with buprenorphine present. There are cases, but really large amounts of synthetic opioids, which she clearly has. She's using, fentanyl and oxycodone, whether it's adulterated oxycodone or separate. It's getting concerning. So this would make me concerned. We'd bring her in for some observed doses, maybe consider the subcutaneous buprenorphine, but use these to really trying to engage and to express concern and support.
So here's another question here from the questions. What is exactly the value of the buprenorphine to creatinine ratio?
So the buprenorphine separately from the norbuprenorphine isn't something I look at unless it is a free buprenorphine. And if it's total, that means it's combined with the conjugate, and I don't find that very useful, although some will look at various levels of the different conjugates to suggest the timing, did somebody recently take their buprenorphine or not. But I find that the metabolite norbuprenorphine, and only if you are able to isolate the buprenorphine itself, which could be very, very, very low to almost not present at the threshold of detection if somebody's appropriately taking buprenorphine. And we can go over that a little bit later. We've got some slides that highlight the usefulness of that, I think, further down in the case discussion. So in 2019, she had these 2 separate episodes of treatment, some disengagement. She was regularly prescribed 60 milligrams of buprenorphine, attempted to get the subcutaneous buprenorphine, but the process, if you're familiar with it, involves ordering, and then the patient needs to give consent to have the medication shipped to to pharmacy, and she didn't complete the consent. So just looking at these results in general, there's a lot of fluctuation in how she's taking the medication. So she's coming off and on, and there's wide variability, which would really serve to drive discussion and support for her. I've included on this next slide a comparison of the oxycodone results, and you can see in general, when there's really low levels of metabolites, she's got really high levels of oxycodone. And I don't have the fentanyl as well, but in general, there was mostly what she was getting was oxycodone adulterated with fentanyl. So you can see how potentially useful the levels are in terms of interpreting, risk and patterns of use. So the patient ultimately had disengaged despite attempts to use peers, on-site visits, counseling, a mix of group versus individual, really trying to try and set to her preference. She re-engages in February 2020, and she reports the same level of opioid use. And an intake urine drug screen is positive for oxycodone and fentanyl. She started on buprenorphine naloxone via an observed dose on-site induction right in early March. The urine screen results from that visit are included below. The patient was not prescribed buprenorphine in the interval from leaving 2019, which is the end of 2019, to re-engaging with the first prescription the morning of induction. What the results below suggest that she was using prior to the induction? Dr. Poland, do you have some thoughts?
Sure, yes, it is. It does look like she was using at least relatively recently. Those levels are pretty significant. Doesn't seem like those would be trending down of any sort, but it sure seems like she was using prior to the induction, and just making sure that you're looking at that individual clinically, because the numbers don't really tell you what a point at which you can start giving buprenorphine. You really need to, because different people have different tolerances, you really need to look at that individual clinically. Most commonly, that's done using the COWS scale, the clinical opioid withdrawal scale. There is also a self-administered version of that if people are doing home inductions, which are becoming more common and more utilized. But I would say the numbers don't tell me anything definitively other than this patient is still appears to be in active use. I can't tell if they've cut back. I can't tell if they're in withdrawal, but those are all things that we would potentially want to observe clinically and have that discussion with the patient about when they last used and what that impact might be on timing for induction.
Sure. And actually she was using illicit buprenorphine, which is the norbuprenorphine and creatinine, is pretty high coming in, not as high as when she left the detox with all doses observed, but she told us she had been taking street buprenorphine, in fact, brought one in and took it in front of us and didn't appear to be in withdrawal. So she, despite having the oxycodone in her system, she was able to do the induction. So buprenorphine and oxycodone were all that was seen. There was no fentanyl this time, so she must have just gotten it simply in oxycodone. And note the buprenorphine is higher and the oxycodone lower, not the greater than 6,000. And so she probably restarted the buprenorphine a day or two prior, or maybe had been taking a little bit more. And it may have been a couple of days, as Dr. Poland had mentioned, since the oxycodone use. Although it's difficult to say specifically. It really depends on how much and she'd been using and some other factors. So now we're in March, and the COVID pandemic is impacting addiction treatment fairly dramatically, and we've got a looming storm on the horizon. So my question to the group is, what types of changes would have occurred that would have impacted a patient with this history? So we have someone who struggled to be engaged, and what types of changes to treatment in March would have been at play that really would have affected this patient's care. Dr. Sullivan.
Yeah, I think what's interesting is that some of the things that happened in March and April end up kind of changing again later on as things change and access to PPEs and other things alter. But early on, I know here in Central New York and New York State, we ended up having an abrupt stopping of outpatient services where they no longer, were on site. And, some places may have been lucky or nimble enough to already have robust telemedicine services, say, in place. And although we rapidly increased those, we were not one of those places day one. So, access to just, immediate, care, 24/7 care, which we do offer, most places do now. We were unable to, at that moment in time, probably provide it as good as we should have, or as good, not as well as we are now, I should say. So just access to care, and probably very for a short time, even access to buprenorphine may have been impacted. Although, as we know, different laws ended up coming out which alleviated some of the constraints of prescribing buprenorphine. But during this exact period of time, for at least a week, 2-3 weeks, there may have been some difficulty in providing the best, the care that this patient needed due to the very beginning of the pandemic.
Right. I mean, in just a dramatic drops in on-site visits, depending on, what type of treatment program, increased prescription duration, less drug testing to really none to start. Some programs were, like you said, very quick to include telemedicine and up and running. And then the regulatory changes that occurred thanks to advocacy efforts from many professional groups and others. It was ACMG, ASAM, AAAP, many different groups. It was important. So the on-site visits for this patient were really critical, doing observed doses, and even with that, she was not as reliable taking the buprenorphine. So I'm very worried about her ability to stay engaged. Dr. Bashevitz, do you have any other comments regarding changes that may have impacted this patient with this history, or in general with the onset of COVID in early March, or at least with the clinical impact in New York State in particular?
Well, I think in New York State, what we saw mostly was that we were asked by our regulatory body, New York State OASIS, to decrease the amounts of visits and decrease urine testing. A lot of people who work in the field became, a little bit uncomfortable with that, but we had to talk about the public health benefits of reducing contact and try and follow the science as things were going on. And of course, now we're in another spike, and we're asking people to follow science again and to decrease testing and visits. We also asked counselors to try and keep patients in the program and not discharge them, just to be more harm reduction oriented. I have a couple of interesting questions in the question box, though. Sure. And one of them, if we're ready for those, Tim, you?
Sure.
So there's quite a few questions, and I don't know that we would get to all of them, but one of the themes here is basically this person is using a lot of opiate-related drugs, and most of the slides seem to say that she's been getting 16 milligrams of buprenorphine, naloxone per day. Why would we not think she needs more than 16 milligrams? Why not just raise her, is what the slides or the question is saying.
So that's a great point. The key, though, is that she's not taking the 16 milligrams. And, as you saw when she came out of detox at much higher levels, and whether buprenorphine is even the right medication for the patient, she had been offered what isn't included. She had been offered to stabilize in an inpatient setting. I declined doing that because she had young children. Consider methadone, and to consider the subcutaneous buprenorphine. And, if she still had craving after a series of observed doses or confirmation that she's taking the buprenorphine, we do increase the dose. And, but the reliability and, the dropping of levels every time there was missed appointments and, suggested that she just wasn't taking the buprenorphine, which was really the primary issue. But yes, you raise a good point. If there's a patient that's taking 16 milligrams and still has craving, increasing to 24, or looking at, other options such as subcutaneous administration or methadone would be the option.
Yeah.
So go ahead.
No, I agree with that. And I think essentially the way we conceptualize this is we didn't have a handle on her yet. She wasn't cooperating with treatment enough to get from point A to point B yet. And we needed to consider other possibilities like other medicines or other levels of care as well. And basically, we weren't there yet for numerous reasons, part of which was her refusal for other levels of care.
Right.
Yeah, Tim.
Yes, go ahead.
So one of the kind of silver linings that we saw with a few weeks after the initiation of the pandemic was the liberalization of buprenorphine prescribing in terms of dosing and duration of dosing and things like that. And we know from at least sort of street sources that the price of buprenorphine on the street dropped pretty dramatically. And so people were able to actually access buprenorphine. I was told in my town, it went from about $8 for 8 milligram strip to about $1, right? And there was just a plethora of drug on the street. Now, it sounds like a nice story when you hear that, and people were having easy access to harm reduction through the use of buprenorphine. But I don't know if everybody saw, but today in JAMA Psych, there was a piece that looked at deaths from overdose, presumably opioid overdose, during the pandemic, and they clearly spiked and went way up. So whether they would have been even worse if we didn't have this extra buprenorphine, or whether this kind of story about having extra bupe on the street doesn't really mean anything, is a little bit unknown. But she maybe had access, you had said, to some illicit buprenorphine based on her urine level, and maybe that's where she got it from.
Yeah. No, and she clearly, when she wasn't engaged, was using some illicit buprenorphine, and even with the fluctuation of the levels, she was continued on the 16 milligrams just with attempts to get her to take it. I did see increasing overdoses in patients, and I have seen at the best continues to see overdoses of patients that are supposed to be taking buprenorphine, but with the less monitoring and checking in, are just not doing well, and frequent in and out of detox with current prescriptions not taking. So I think that there's a population that with the less monitoring, it's hard for them to take the buprenorphine. So looking at other options, I've seen many fatal overdoses. I think that needs to be teased out as we look at the data from the increases overall. What has been the role of the monitoring and more liberalization of buprenorphine. One thing that we did have in our area that I didn't mention was pharmacies started delivering medications, and a lot of our patients had trouble with lost prescription. With at certain points, some of the riots related to social injustice and racial injustice, and George Floyd had resulted in parts of town having damage and some pharmacies being closed. And so we really had to be nimble despite, having a skeleton crew on site and less contact, at least directly with patients, because even at the pharmacy level, there were problems, and early on, even stocking and being able to be flexible. So some dramatic.
I think you're bringing up some of the social concerns that have happened over this, the year of 2020 is really important in this. And that, as we've looked at COVID, and what we are recommending for our society is social isolation, right? And we've known for decades now, the work of Bruce Alexander and the Rat Park studies, that isolation is a marker for worsening substance use. So as we interpret some of this information, what contribution do these external forces have on our patients? What contribution does it isolate, that social isolation, has that had on on our communities and on our individual patients. I mean, I don't require all of my patients to go to AA or frankly be in any kind of therapy, because there hasn't been concrete evidence that therapy is a necessity for all patients. But certainly the majority of my patients, all of my patients are at least offered it. But for the ones that take that up, that whole landscape has drastically changed in that human connectedness, right? That three-dimensional being in the same room. We all are getting Zoom fatigue, right? We're all experiencing this as our patients are. And what contribution has that social isolation had, which we know already pre-COVID contributes to substance use? Has that clouded the benefits of some of this telehealth and some of these changes that we've made in other spaces? I don't know that we'd be able to tease that out, but I think before we draw any conclusions about this time, that we need to be sensitive to that.
Sure. Certainly some people have done really well with the access to Zoom. I've had patients that have enjoyed participating in AA or NA or other meetings internationally, even in the hospital setting, as they've been hospitalized related to complications from substance use, or at home. But others just simply, that is not a model that works well for them. They need the human contact, and our use of the peers to go into the community to meet people where they're at has really been limited dramatically, in particular during the surges. There have been guidance. I want to highlight the ASAM guidance related to COVID, which is updated and had created a series of topics, in particular related to all levels of care of addiction medicine. One of the features today, obviously, is drug testing, and ASAM had put together a evidence-based expert panel supported paper on drug testing, clinical addiction medicine, that several of us were involved in, Dr. Nelson and myself. And the adjustment of drug testing protocols has been one of the most downloaded documents from the ASAM website. So people clearly looking for guidance on this area with COVID-19, among other things as well. So let's move ahead with this patient. The patient's prescriptions are increased to biweekly with on-site check-in from weekly prescriptions pre-COVID. This is most of those as well. She's sporadic contact, agrees to try the subcutaneous buprenorphine, which is ordered. She completes the consent process, delivered, but she disengages as the medication arrives, and ultimately the order has to be wasted per the waste protocol. And during this past several phone calls with the counselors and the providers, she was slurring speech, sounded extremely intoxicated, and a welfare check was requested. And she's found intoxicated with a young child on site, resulting in a CPS case referral. She disengages after this, but did call back again in October. There were some delays with the CPS plan. I think all levels of social services have been thin because of a lot of factors pertaining mostly to COVID. And she wants to restart buprenorphine and get back on track in medication. So at this point in October, what are your thoughts for this patient? She refused detox in inpatient, and apparently the CPS case, they will not enforce this unless she's not engaging now with this next chance at outpatient, or they failing, what's called, and I wouldn't use that word, but that was the specific terminology. So any thoughts, Dr. Bishevitz?
So this one is kind of like a catch-22, especially with all the COVID-19 concerns. And basically, you face the challenge of maybe saying no to her and saying, no, I'm not going to give you any kind of buprenorphine or Sublocade now, because I really think you need some higher level of care, such as inpatient or methadone maintenance. And I know that, people have all sorts of feelings about that in terms of the COVID epidemic and a call for more harm reduction. But sometimes, especially when you've talked with a patient so much and there have been so many difficult episodes in treatment that she hasn't got through, you might think of just telling her that a higher level of care is needed and see what she does.
Right, I agree. I think it's uncommon from my practice that I will not prescribe and try again, but I have had a patient recently that with each prescription of buprenorphine, he's overdosed, not on the buprenorphine, but on, after a binge right after getting the prescription. And so, clearly a situation offered if it stabilizes an inpatient, but not just simply through remote prescription and not at observed doses. So we did try to do reinduction, wanted to do one last try. She's scheduled for an on-site induction due to prior episodes of not taking. We have had high-risk patients on site as well as the inductions, and bringing in occasionally for drug testing, still less frequently. Some dipstick if it's thought to be important. Some CPS cases that have requested confirmation that they're doing well. It's important for their social situation. So we've opened up some on-site visits, but really the groups and most counseling will occur outside. Still a skeleton crew on site. And the intake coordinator reports she sounded off when calling, and the patient admitted she'd been using again the day she called. She said she thinks it's fentanyl, not actually perks. At the on-site induction, the patient takes an 8 milligram film appropriately. She brought one of her own again, and she agrees to a telehealth visit 2 nights after. This is via an app. There's several, Zoom, Doxy.me. Prescription for 8 milligram, 8 days is sent to the pharmacy. Counseling, group sessions, and peer contact via telehealth are set up, so we move forward. So this is the results from her induction in October. She's low norbuprenorphine to creatinine, so she's using a little bit of illicit buprenorphine and no oxycodone. It's just fentanyl, high levels of fentanyl. So these are essentially, if she's using adulterated oxycodone, they're really just fentanyl and filler. Some question, Dr. Sullivan, what platforms and mechanisms are providers using for telehealth evaluations for group, physician or advanced provider evaluations, MAT initiation or follow-up visits? Are there any particular novel telehealth support methods that others have found for patients? I think the two most common that I've been using are the Zoom platform and the Doxy.me. I know there's a number of other approved platforms. Just what are your thoughts?
Yeah, in terms of platforms, we've used those. We've used Zoom. We've used, Microsoft Teams. I mean, I think there's quite a few different positives and negatives to each one of them. Some of them, allow people to use any type of internet connection, and they can click a link. There's a lot of different platforms out there right now. I think that, the biggest thing, that, we think is, does telehealth work for certain situations? And we know that telehealth does work and that patients do like it. But what's interesting is that we really now have a dichotomy of telephone versus video now. And, it's a question of, does telephones, is it just as good as video? And some of these questions are still being answered. We did do a self-study here that we're looking to maybe try to publish that showed, though, that in terms of the height of COVID here and then through the summer, what we found is that engagement with primarily phone for MAT visits was about the same pre-COVID and then during COVID when we went to telephone. And the same thing held true for individual and therapy appointments, that people were still remaining connected with their therapists and counselors. But what was interesting was that trying to conduct groups over a video, which has a lot of different problems and, HIPAA type things and laws, but even using voice groups, we found that the participation in those dropped precipitously trying to use what we do every day for meetings. Now, that might just be something here in local, but maybe it's hard to do a group with 10, 15 people just over a telephone group chat. Maybe even things like groups over video, where we have a lot of people who don't have the capability of doing video. So all these things have to really be, taken into account when you think about what works for your patients. I will note that the patient we're talking about here, we're saying, well, outpatient's not working for her, but in some ways, just talking to her on the phone and having a good peer support is kind of working for her. We're keeping her engaged. We know that she's having some periods of being altered and lethargic, maybe with some other drugs or alcohol. And, maybe she'd be doing better. I use this word in quotations, maybe if we had a formal outpatient for her, but just using telephone with a good peer structure in some ways though is still supporting her to getting back on some medication. So I do want to say that telephone, maybe not be the best, but does I think have some efficacy during COVID right now.
Yeah, those are great comments. I think I agree. When I have regular contact via phone, if that's the only mechanism, and I see that they've had consistent attendance and sound good and are making their appointments, it typically I'm not as concerned. And even when we've brought patients in for confirmation, that validates my thoughts. So just moving ahead, the patient has a scheduled observed dose, and she answers a call notifying her of the telehealth appointment, but doesn't log into the waiting room despite 2 more calls for over 20 minutes. When she finally does, she's in a dress, she has makeup on, is in a dark room, not at home. She quickly takes what looks to be the buprenorphine film. The protocol for the telehealth calls are reviewed with her, and to be available and have the medication ready. We call ahead, then do the telehealth if it's a video call. She's scheduled for an on-site visit and for a urine and observed dose because of concerns. We also discussed ordering the subcutaneous buprenorphine again, although with their on and off regularity, we really want to confirm that she's actually taking the buprenorphine to get the shot. She's never gotten the shot, but are considering, even if we can get a couple of days that we know that she's taking it, she's going to be able to get the shot if she agrees. At the on-site visit, the patient's anxious. Is an open wrapper. She explains it because she thought she could do the observed dose with the front desk administrator. The urine screen is obtained, and the dip demonstrates only buprenorphine, and it's sent for confirmation. Normally don't do the dips, but I wanted to make sure she had at least some in. And so I'm going to jump ahead from protocol for on-site visits during current COVID-19 surge, and we can talk a little bit about after we talk about what occurred at her visit. As the patient does the observed dose, the provider doesn't see the film going into her mouth and asks to see it under the tongue. When she does show the film, it's clearly wrapped in plastic, not just a normal film. And she pulls out a piece of buprenorphine naloxone film, not a complete piece, wrapped in plastic. And she says, "I forgot to take the wrap off." The guy in the waiting room outside, the patient actually was outside of the building, had been in earlier, gave it to me to use to cover it up after I couldn't do the dose with the lady up front. So I'm wondering, what would you do in this situation, Dr. Bishevitz? Would you have her unwrap and take it, or?
I would try and inspect it to see if I thought it looked like a regular film. That would be number one. And I would think that she's very, very creative in what she's saying here.
Yeah. So we did take a look at it, and it was buprenorphine wrapped in plastic. And she's advised of the risks related to taking it if she's not taking buprenorphine and using other opioids, and that being precipitated withdrawal, or if not taking it at all, which I didn't think she's taking any opioids because she's either taking oxycodone, fentanyl, or buprenorphine. And she does take it, but swallows it quickly. We do an oral swab after the sublingual administration. Couldn't find the oral swab, not doing a lot of those on site, and the patient is anxious about this as we're doing the oral swab. She's counseled regarding the testing, observed doses, goals of care, simply want to have her healthy on the appropriate medication, safely get her stability and through CPS, and then she confirms again that she wants to get on the Sublocade, and another observed dose visit is set. She answers the call for the telehealth visit, and she sounds surprised, simply that there's a call, and acknowledge the visit. She'd be on, the link is sent, and several calls later, no arrival, does not log in. Message is left, no follow-up, no answer to follow-up visit, and her results return from the urine test. And the urine done prior to the observed dose is on the top, and you can see buprenorphine at very high levels, norbuprenorphine is negative, and naloxone is at very high levels. And then the oral swab taken after her observed dose, which was with the unwrapped buprenorphine, and you can see the results. And I'm wondering what your interpretation of this is, Dr. Poland.
My heart goes out to the whole group. I mean, especially this patient. It sounds like she's really had a difficult run of things, and engaging her has been hard and at best. And so, I mean, but I just have to think when I have these situations that at some part of this person wants to get into treatment because she keeps coming back. And that, I think, is a kernel of promise that sometimes we miss in a situation where somebody is struggling as much as this individual. Well, it looks like, unfortunately, she was placing a strip of buprenorphine naloxone into her urine cup, and that was not a metabolite. There's no metabolite of buprenorphine as norbuprenorphine in her urine, and the naloxone level is quite high. And then in her oral cavity, it looks like there are some other opiates also in there, indicating that she also has another source other than buprenorphine for opioid.
Right, exactly. Patient does not answer the calls from the provider. She schedules an appointment with a local clinic known to simply prescribe monthly prescriptions without monitoring or check-ins. She's intermittently connecting to counseling and to the peer about 1 out of 3 visits, which is satisfying CPS for the counselor, and ongoing team meetings to discuss options. At this point, Sublocade is not offered because of the kind of disconnect with medication, and she was offered to stabilize a detox or inpatient and then get the shot, but that wasn't followed through. Just a little bit about specimen validity testing. Dr. Nelson, in particular with regards to this test, which was a separate test, what constitutes specimen validity testing for urine and oral drug test specimens?
I mean, you're largely what you're seeing at the bottom of this screen. You're looking at things that can include temperature, as well as some of the testing that you can do, like pH and dilution, that would look at things like specific gravity. I mean, in her case, they're actually fairly generous with their ranges, if you ask me, because her specific gravity is extraordinarily low, below what you would expect most people, I think, to be at the lower end of the spectrum. Her creatinine is very low, implying that she's diluted her urine. The pH is in an okay range. So you could really ask whether or not this is a valid specimen based on this alone.
Yeah, so you hit on points of temperature, creatinine, specific gravity, pH, markers that the urine is valid and didn't get diluted. There's different ways that we could get into, discuss, but for the lack of time, we want to make sure a specimen is truly a good specimen. In oral saliva, there's IgG that is sometimes used as a marker that a valid test was obtained. We have a really brief case too, different results by matrix. The oral fluid doesn't match the urine. This involves a 27-year-old female with opioid and stimulant use disorder who is struggling with cocaine while being prescribed buprenorphine. CPS is involved. She had a significant other that assaulted her, although they withdrew charges. Both agreed to enter treatment. The 3-year-old autistic son lives with mother. Significant others staying with at the house. Patient wants to demonstrate she's doing well. The CPS is asking to come on site to do urine screens despite the COVID-19 limitations. And we've already discussed some of the exceptions that we've made for on-site visits. And, this would be a very valid exception, with PPE and the right protocol to bring in. Again, some other examples that I've included and we've discussed. Patient reports she's doing well, although she's missing counseling sessions, and there's been a couple of more police reports. The urine from the first on-site visit show no illicit substances, and she's got a little bit low norbuprenorphine and creatinine ratio, but she's taking buprenorphine. After learning of the police visit, another on-site screen is done, and this time the oral testing is also done, as the clinic is also rolling out an oral testing protocol via telehealth, so an ability to do oral testing remotely through a secure process. And this is, again, a discrepancy with the urine to the oral, and she admits that she'd been bringing in urine to avoid trouble with CPS, but it was just that time, though. We've already covered the utility of oral versus urine screens. And Dr. Sullivan, this is, I think, one of my final questions. what is your experience with remote drug testing, and you had success with secure oral saliva testing protocols?
Yeah, so we actually wrote a protocol here at Helio Outpatient, where we use a lab company. We've been able to send oral swabs to patients at home in discrete packaging. The first to tell you that, I care, but I really don't care. I tell everybody that the drug screening release for conversation to make sure patients are okay, to see if there's anything more we can do with them. We never discharge anybody ever, based on drug screening. And it's just, I really want to make sure people are okay. So, we always preface it with that, saying, we just want to make sure you're okay. So we try to avoid some of this test manipulation things, but we don't do it, every week, maybe once a month, just to get an idea if people are doing okay. So they have a discrete package sent to their home. It doesn't say like drug screen on it or whatnot. And we let people know they might get a couple of them throughout the months or year, and we want them to do them. At first, we tried to do it like on video, and then I decided I don't know the utility of having to watch them, and we instill some trust, and we let them do it after the first time on their own when they get the kit and they send it back to the lab, and then we get the results. Someone will say, well, what's stopping them from, doing something? Well, there are different ways to maybe alter saliva tests, although I think they're not like they used to be. They used to talk about people putting baking soda in their mouth or milk and all this stuff, and I don't know how true this stuff is. But, if you have a lab that also tests for other medications that patients are on, in addition to the buprenorphine and the metabolites, you tend to not get too many samples that are, from somebody else because there's, or tampered with. So, the hardest thing is that in this time of COVID is, getting people to do it. And because we're open up front, we tell people, hey, there's no repercussion to having positives or negatives. The uptake of the actual system is a tough thing. We were looking at it for about 50% participation, getting samples back. We're slowly moving up now towards 30%, and we have thousands of outpatients. So we think that we're doing decent with it. We'd like to just, do a little bit better because we want to make sure, see how people are doing. And maybe ends up being, wow, someone's really, maybe you are struggling, maybe we can then set them up with a peer or talk to them on the phone more. Do you need a different support or detox or inpatient? But we really do it to just make sure that we're, giving the patient what they need to be as safe as they can be.
Some great points. And, other areas, sports, athletics, NCAA, I believe, Olympic athletes, this is a protocol that's been tested in other areas. But again, comments about, it's a piece of the information, not the be all end all. We're really coming to the end of the time. I just wanted to comment that, so again, the clinic that this patient's at is rolling it out, and we'll use it in the same way that you kind of described. I've got the final slide. I've been ending with a poem. I think that this is kind of fitting given everybody the stress. And so I just want everybody to listen. This is from Richard Brodigan. Some call him a beat poet, but really not quite appropriately just a beat poet. 1935, died of a suicide in 1984, called Karma Repair Kit, items 1 to 4. Karma Repair Kit, items 1 to 4. 1, get enough food to eat and eat it. 2, find a place to sleep where it is quiet and sleep there. 3, reduce intellectual and emotional noise until you arrive at the silence of yourself and listen to it. 4, I want to thank everybody for attending. Thank you, panelists, for participating today. We had some great discussion. We will have summaries of the cases, and some of the key questions that will be embedded at the ACMT website and available. Please complete the questionnaires and surveys. We really do take a look at that, and for content and feedback on the presentation. Mark your calendars for the next Friday Addiction Toxicology Case Conference on January 8th. This one will focus on the emergency department, hospital initiation of buprenorphine and bridging, and particular pertinent area with a lot of interest. So thank you all for attending, and have a great weekend and stay safe.